Hi everyone, my name is Tiffany, and today I'll be giving a brief presentation on my topic, Chapter 29, which was over multiple gestations. So let's go ahead and get started. So the rate of multiple gestations, particularly with twins, has increased greatly in the past decade, while the rate of higher order gestations, such as triplets, quadruplets, etc., have decreased, with twins representing 1 in 100 pregnancies, and quadruplets only being 1 in 729,000. The increased rate of multiple gestations is mostly due to women waiting longer to have children and subsequently needing to use ART or assisted reproductive technologies more often. And these include gamete intrafallopian transfer, intracytoplasmic sperm injection, and in vitro fertilization. The most common clinical reason to suspect multiple gestation is a larger uterine size than expected for gestational age, as well as detecting 2 or more fetal heart tones using Doppler and higher lab values, specifically higher levels of maternal serum alpha fetoprotein or MSAFP. Multiple gestations has quite a few complications. On the maternal side, you have increased risk of hypertension, preeclampsia, C-section, placenta previa, placenta abruption, postpartum hemorrhage, and a higher mortality rate. On the fetal side, you have increased risk of morbidity and mortality, preterm labor, intrauterine growth restriction, congenital malformations, fetal abnormalities such as twin-to-twin transfusion syndrome, twin reverse arterial perfusion sequence, and conjoined twinning. Because multiple gestations are considered high-risk pregnancies, periodic sonographic exams are important to monitor maternal and fetal health. It plays a critical role in determining the type of twinning, the presence of abnormalities, as well as monitoring concordant growth of the twins. Ultrasound is also used to guide procedures such as selective reduction. However, before we discuss what to look for in sonographic exams, we first need to differentiate between the two types of twinning. We have dizygotic twins, which make up 70% of all twins, and this occurs when there is fertilization of 2 separate ova. And the incidence of dizygotic twins is influenced by genetics, environment, advanced maternal age, and ART usage. With monozygotic twins, this occurs 30% of the time. It's a random occurrence, and it happens when a single ovum divides after fertilization. The placentation, or the combination of placental membranes of a dizygotic twin, is always di-di, meaning diamnion, dichorion, and that's because they come from 2 separate ovum, which are separately fertilized, and that's why they have 2 separate amnions and chorions. With monozygotic twins, because it is from a single ovum, the placentation is determined by when the zygote division or the cell cleavage begins. So if the division occurs before 4 days, it will be a dichorionic diamniotic pregnancy, and this occurs 25% of the time. If it occurs 4 to 8 days after fertilization, then it'll be a monochorionic diamniotic twin, which occurs 75% of the time. And if it occurs anywhere after 8 days, it'll be a monochorionic and monoamnionic twin. This only occurs about 1% of the time, and even more rare would be if it occurs after 13 days. This will result in conjoined twins, and this occurs 1 in 50 to 100,000 births. So going back to the ultrasound exams, in the first trimester is the most accurate time to determine the chorionicity and amnionicity of the pregnancy. With the chorion, if you have 1 gestational sac, that means it's monochorionic. If there's 2 gestational sacs, that means it's dichorionic. And then with the amnion, a very similar thing. If you have 1 yolk sac, and of course you'll have 2 fetal poles, then it'll be monoamnionic. And then if you have 2 yolk sacs with 2 fetal poles, it'll be diamnionic. As you can see in this first trimester image, there are 2 gestational sacs and 2 yolk sacs, which mean it's a dichorionic diamnionic gestation. In this image, you only see 1 gestational sac, but still 2 yolk sacs, which means it's a monochorionic diamnionic gestation. Then lastly, we have this image in which you only see one gestational sac and one yolk sac, meaning it's a monochorionic, monoamnionic gestation. Once we get into the second and third trimester, we're still going to want to make sure we're determining the chorionicity and amniosity. However, this time we're going to be using the number of placentas, the presence of an intertwined membrane, and their genders. With placentas, if you have one, it's monochorionic, two is dichorionic. The intertwined membrane, when you have a very thick intertwined membrane, which means it's the lambda sign or also called the twin peak sign, that means you have a dichorionic, diamnionic gestation. If it is a thin membrane, which is the T sign, then you have a monochorionic, diamnionic gestation. With genders, if it is different genders of the twins, then you know it is a dichorionic, diamnionic twin because that is coming from, like I said earlier, the separate ovum. That's why they can be different genders. However, if they're the same gender, you can't really tell if they are dizygotic or monozygotic because both of them can have same gender twins. So now that we've covered the basic information for a normal multiple gestation pregnancy, we can begin talking about all the abnormalities. So the first abnormality we'll be discussing is the twin-to-twin transfusion syndrome, which occurs in about 10 to 15% of monochorionic diamnionic pregnancies. And if there is filamentous cord insertion present, there's an associated 50% risk of having the syndrome. In this condition, the twins have an arterial to venous endosmosis in the shared placenta, meaning that the returning blood from one fetus is moved directly into the other, which causes an imbalance of blood perfusion. This causes the recipient twin to become larger and eventually develop polyhydramnios, whereas the donor twin becomes smaller and develops oligohydramnios. And the oligohydramnios causes the amniotic membrane to encase the twin, which causes it to have a stuck appearance. CTTS usually presents in the second semester, but it can occur earlier and that would have a poor prognosis. And if it's left untreated, there is a 60 to 100% mortality rate, not just for the donor twin, but actually both of them. So in utero, there are a couple different treatments, but it really all just depends on the gestational age of the twins. If this is found in early pregnancy, then most likely there will be a selective termination of the donor twin or a complete termination of the entire pregnancy. In the second trimester, you can have a seroreduction amniocentesis, which is the first image in which they just go ahead and take out some of the amniotic fluid so that way it returns to a normal level. You can have a septostomy of the amniotic membrane, in which they basically just poke a hole through the amniotic membranes. And in essence, this makes it so that the pregnancy is almost like a monoamniotic one. However, this one is not really used all that often because there's a lot of risk associated with a monoamniotic pregnancy. And the last one, and the third image, is the laser or radiofrequency ablation of the anosmosis, which means that they just cut off the connection. That one has a really good success rate and it's used, like I said, most often. So if we're looking at a sonographic image of the TTTS, in this image you can see that the donor twin on the top looks like it's stuck to the uterine wall, and it all has an almost non-existent bladder, whereas the recipient twin has an enlarged bladder. We also have the twin reversed arterial perfusion sequence, and this is a rare complication of the monochorionic gestation in which there's one normal or pump twin and one amorphous or acardiac twin. In this condition, the twins have an arterial to arterial and venous to venous anosmosis in their shared placenta, which causes a retrograde blood flow from the pump twin to the acardic twin through their umbilical arteries. This means that the acardic twin is getting deoxygenated and nutrient-poor blood, which is why only the caudal portions of the fetus is formed and their cephalic structures are completely absent or severely maldeveloped. And because they don't really have a heart, that means that the acardic twin is hemodynamically dependent on the pump twin for all of its circulation. This causes the pump twin to be at a 50% risk of morbidity and mortality from congestive heart failure, non-immune hydrops fetalis, and polyhydramnios. And that risk increases with the increased size of the acardic twin as the pregnancy progresses. There is a 92% survival rate of the pump twin with the usage of radiofrequency ablation of the umbilical cord, and that survival rate is actually increased with early diagnosis and intervention, which is kind of the opposite of the TTTS, because in TTTS, if you actually diagnose it early, or if you see it early, then that's actually a bad sign, but in this case, it's the opposite. So with conjoined twins, this is a very rare condition, which, like I said earlier, this only occurs when the cell cleavage happens after 13 days, and this is specifically only in monochorionic, monoamnionic twins, which makes sense because if they're conjoined, then they have to be sharing, at least an amnion. This also means that since they're coming from a monozygote, that they will be the same sex, and 70% of conjoined twins are actually female. They are classified by the area in which they are conjoined. So you have your thoracopagus, omphaliopagus, craniopagus, pygopagus, ischiopagus, cephalothoracopagus, and there are a couple more, but those are the main ones. And most conjoined twins are actually born premature with a 60% mortality rate. Sonographically, you'll see that they have a lack of a separating membrane. You're unable to separate the fetal heads and bodies even as you move your transducer and as the fetus moves itself. And there are more than 3 vessels in one umbilical cord. There's also another condition called the fetus in fetu. This is when there's a parasitic twin found in the abdomen of its sibling, and it's very important for us to distinguish this from a teratoma because the fetus in fetu is actually of a benign nature, whereas a teratoma has the potential to become malignant. So the fetus in fetu is usually in the upper retroperitoneum, and if you don't see like a full-on fetus in the abdomen, usually there will at least be some evidence of a vertebral column. You can also have a vanishing twin, which is when a twin gestation is diagnosed in the first trimester, but as you go on with your ultrasounds, one twin vanishes. So this is a spontaneous demise of the fetus, and the rate at which it occurs is actually similar to the spontaneous demise in a singleton pregnancy. And there are no adverse outcomes to the surviving twin in this situation. We also have the fetus paparesius, and this is when there is fetal loss in the second or third trimester or in a monozygotic twin gestation. So what happens is that the fetus, once the fetus dies, instead of being absorbed into the body, it is actually preserved in this distorted, like paper-like form. Yeah, and that is what a fetus papricus is, but it's not anything harmful to the twin. Now, in cases of serious complications to the fetus or to mom, or you have a lot of anomalies, in certain states, you can have selective reduction. And in this case, what will happen is the potassium chloride will be injected into the fetal heart or umbilical vein. However, this can only happen in dichorionic pregnancies because if you attempt to do this in a monochorionic pregnancy, since they share placenta, there can be adverse effects and even mortality to the other twin. And that is all for my presentation. Thank you so much for watching, and yeah.